Welcome to the US EPA's webinar on population health situational awareness, getting the data you need to build equity in child asthma outcomes. Hello, my name is Dr. Mary Jo Errico, and I'm a scientist from EPA's Indoor Environments Division's Center for Asthma in Schools, where we are champions for children with asthma who need our help to catch a breath. Next slide. Here you will see our agenda for today and what we will discuss. Next slide. This is our second webinar of 3 in a webinar series on solutions for the indoor environmental determinants of health. We had about 600 registrants for this session, and our audience is from across the nation. This map shows the states represented in our audience today, with the white states having no participants registered and with the darker shading representing higher number of attendees. Next slide. As we begin, I would like to ask everyone to please take a moment to participate in our Learning in Action poll. We want to have some idea of how knowledgeable you feel as you come into this discussion about population health situational awareness. We want to know, do you know much about using data and analytics to reveal where indoor environmental factors may be contributing to community asthma burden? We will repeat this poll at the end today to compare before and after to see if we are meeting our learning objectives. Thank you for participating. As you participate in the poll, I also want to let you know before we begin today that we will be using the chat function in the webinar interface to collect your questions throughout the presentation. We will monitor the chat throughout the presentation to prepare a question and answer panel discussion at the end of the presentation. Please use the chat function throughout the discussion today to share your thoughts and questions for our speakers. Finally, we are recording today's session to make it available on asthmacommunitynetwork.org, and all participants other than our speakers will be muted throughout the session. Thank you, Pierce. So it looks like many of you know a little bit about using data analytics, but want to learn more. That's great. That's what this webinar is all about. Pierce, you can go to the next slide. Again, I would like to welcome you to the second session in our 3-part webinar series where US EPA's Indoor Environments Division, or IED, is sharing solutions that any community or state can adapt and apply to address its indoor environmental determinants of health to improve asthma outcomes. For about the next 10 minutes, I will set the stage for our presentation from Dr. Andrew Beck and conversation with cross-sector leaders from Cincinnati with a little information about IED's solutions for the indoor environmental determinants of health, or IEDOH. At IED, we build capacity with communities in environmental asthma management with the key drivers of high-performing asthma programs. That is what you see on the right of the screen. We have learned in our more than 20-year mission to promote environmental asthma management as a standard of care that when cross-sector leaders and champions in a community commit to deliver asthma care through collaborations and partnerships that integrate community and clinic with strong ties to the populations most affected by asthma and a focus on addressing their care needs so that tailored environmental interventions can reach children with asthma who need them. High quality asthma care results. Asthma comes under control and kids can catch a safe breath everywhere they spend their time. IED has learned that when communities assemble these drivers, they make high quality asthma care systems possible and make them run. Another way to say this is, asthma systems improve outcomes with environmental management when they break down silos. That is what this graphic shows. This is the community solution IED champions, and this idea is what we are going to hear all about today. What it takes to break down those silos and really partner so that the right care can reach the right children where they need it, and how getting the right data is key to making those partnerships and collaborations run. Next slide. At IED, we have worked with and studied high-quality asthma care systems like the Cincinnati model we will learn with today for more than 20 years. We always seek to shine a spotlight on excellence where we see it, so all communities can learn from and adapt their own version of what works. As we have promoted this system, a silo-breaking solution to get environmental asthma care to the children who most need it in any community, we notice its echo, its close cousin, cropping up all over in the frameworks for the social determinants of health, or SDOH. We see that communities with systems for high quality asthma care already have SDOH solutions that healthcare is looking for in its search for accountable care partners. When communities solve for IEDOH and asthma, they solve where housing, healthcare, and disparities intersect, an intersection where SDOH overlap and pile up, especially for poor children. IED's system for high quality asthma care is an SDOH solution. This is our learning to share. And as we will hear in the Cincinnati model, the data communities need to power cross-sector partnerships shows why asthma care that looks like this system picture is an SDOH model. The data is the story. Getting and sharing the data powers community asthma systems, and using the data to design a high-performing asthma care system is solving for the IEDOH. Next slide. IED helps communities to build systems to address the IEDOH and asthma disparities because that is the lens that brings into focus the critical role of in-home environmental interventions in comprehensive asthma care. That is where IED overlaps with Dr. Beck and his colleagues in Cincinnati's asthma research and programs, and has for many years, where asthma, housing quality, indoor environmental exposures, and health disparities meet. Today, as we host as many stakeholders from across sectors as we can reach to shine a spotlight on Cincinnati, we want to help everyone hear that, one, there are technical solutions for the IEDOH and asthma that all communities and programs can use and benefit from, and two, partnerships between healthcare and community services to address the IEDOH and asthma are model solutions for asthma care, SDOH, and health equity. Next slide. Today, we are focused on population health data and cross-sector analytics and partnerships to support IEDOH interventions in asthma. In our previous session, we looked at innovation in financing and Medicaid for asthma home visits with environmental interventions and multidiscipline workforces. And in our final session in this series on the IEDOH, which we expect will occur in February or March 2023, we will look at blended healthcare and housing sector financing and workforce to support and sustain community-level IEDOH solutions. We will build out resources related to these webinars on asthmacommunitynetwork.org. If you aren't yet a member, make sure to join so you will not miss these and many more resources. We have been building the Asthma Community Network since 2008, and there's a great deal to find and learn there. Our next webinar will also be announced on the Asthma Community Network, so if you are a member, you will hear about it and have a chance to register. Next slide. Today, we are honored to host Dr. Andrew Beck as our speaker. Dr. Beck is an associate professor at the University of Cincinnati College of Medicine and an attending physician in the divisions of general and community pediatrics and hospital medicine at Cincinnati Children's Hospital Medical Center. He received his BA in anthropology from Yale University, his MD with a concentration in underserved medicine from the University of Pittsburgh School of Medicine, and his MPH from Harvard University. He completed residency and fellowship training at Cincinnati Children's. At Cincinnati Children's, Dr. Beck is a faculty co-lead for population and community health and the All Children Thrive Learning Network. He is also medical director for population health research and innovation for HealthVine, Cincinnati Children's Medicaid Accountable Care Organization. His research and improvement interests focus on the intersection of neighborhood and health, the social determinants of health, and population health equity. Dr. Beck's work has received grant funding from federal and foundation sources and has resulted in nearly 150 peer-reviewed publications. He practices clinically as a primary care and hospitalist pediatrician. Dr. Beck will present on community-wide work that involves many others in Cincinnati. We're happy today to also have 3 other members of the team join our panel discussion after the presentation. We'll be also hearing from Dr. Lisa Crosby from Cincinnati Children's Hospital Medical Center, Dr. Patrick Ryan from the University of Cincinnati College of Medicine, and Dr. Marisa Mean from the Cincinnati Health Department. After Dr. Beck's presentation, we will transition into a conversation with this amazing team of Cincinnati Asthma Champions. With that, it is my privilege to turn the presentation over to you, Dr. Beck.
Thank you so much, and for that really nice introduction. And thanks so much for having us today. And thanks to all our attendees. It's a real privilege to be able to present some of our work, share what we've learned, and ideally learn from all of you. It's a special privilege to join in this presentation today with some colleagues, friends, and collaborators, and in many cases, mentors who you'll meet later in the hour. But what I wanted to do was set the stage by providing some background on what we mean by population health situational awareness and how we can bring data to life in order to drive toward equitable outcomes for our kids. Here are my objectives for the next 45 minutes or so. First, we will consider how and why certain patients and populations are disproportionately burdened by asthma morbidity. We'll then think about how we might employ situational awareness to inform collective action in meaningful ways, and importantly, how we can use this to drive toward interventions that aim to improve asthma outcomes for children and communities, patients, and populations in ways that are truly equitable. But to start, I want to pick up on a theme that I just heard in Mary Jo's introduction, this idea of data as the story. And I think in medicine, and in many respects in public health too, the stories or cases that we experience are particularly formative. And so in that vein, I wanted to tell a brief story of a child I met during my training, an experience that has been particularly formative for me and for where I spend my time during my practice now, and where I hope my career goes in the coming years. And so I'd like to take you back. I was a pediatric resident at the time. One of our rotations was to work through our pediatric emergency room. And as senior residents, one of our responsibilities was to carry the so-called trauma pager. And this pager was there to alert a multidisciplinary team of doctors and nurses and respiratory therapists and more to respond when a trauma was coming through our doors, or when a particularly ill child was coming through our doors. And one evening, I think it was about midnight, that pager went off, and a whole team of us rushed to the trauma bay, a room where we could provide quick acute care to the child that was coming through. And we didn't know much at the time of what was coming our way, but the squad had called in advance. They were bringing in a 9-year-old girl, a child who had developed increased work of breathing in the day prior to that presentation, but it had really gotten bad in the hour or two before the family called squad. The squad noted her to be in great distress, seemed like an asthma exacerbation, an asthma attack, and they started whatever medicines they could and oxygen en route to us in that trauma bay. When she was wheeled into that room, this child was in severe distress. She was having a ton of difficulty breathing, and you could sense that her respirations were tight and distressed. And unfortunately, before long, she stopped breathing on her own, and soon thereafter, her heart stopped. Now, my role in that particular day was on the side of her bed, rotating on and off, doing chest compressions for this child who had gone into cardiac arrest. Me and one other person rotated off and on for 30 minutes while other members of the team were focused on her airway, on medications, on monitoring, and leading that team through this code. And unfortunately, after about a half an hour, the decision was made to stop that management. We were not going to get this child back. So here we had a 9-year-old die right in front of us from an illness whose manifestations, whose symptoms should largely be preventable. There were a few things we learned after the fact. This was a child who lived in a set of apartment buildings known to be fallen into disrepair. This was a family whose parents had to work multiple jobs to make ends meet, making it very difficult for her to attend preventive visits during normal business hours. And perhaps the thing that has stuck with me ever since is that this child traveled to us from about a mile away. So here we are, this big gleaming hospital, and this child, less than a mile from our doors, succumbed to a disease whose symptoms should be preventable. This is the formative type of case, the story that is motivation for us to move in the direction toward better and meaningful outcomes. Now, as I pivot from that story, from that experience that perhaps many of us have had at least something similar, I want to provide some background into how we can take a formative experience like that and move in the direction of improvement. And to start, I want to define a couple key terms. In the title of this talk was population health. Now, population health has grown in use across medicine and public health, and it's been defined according to this paper from 2003. This is a paper from Kindig and Stoddard in the American Journal of Public Health that defines population health as the health outcomes of a group of individuals, including the distribution of such outcomes within the group. The distribution is a key aspect of this. It's not enough to say what the average outcome is. It's important to also know what that distribution is. Now, when we think about inquiry, when we think about research, we can define population health research as the study of the conditions that shape the distributions of health within and across populations, and of the mechanisms through which these conditions manifest as the health of individuals. I'll highlight a couple of things here. What are those conditions that shape the distributions? What are the mechanisms through which they work? Indoor air exposures are certainly part of that equation. So then with this in mind, as we think about pursuing population health, I would suggest, and I'll frame the next 40 minutes or so using three key questions. First, why are certain children more likely to face preventable morbidity and in some cases, mortality? Second, why are certain communities more likely to face that preventable morbidity and mortality? And finally, how can we use answers to these questions? How can we use shared situational awareness to move with urgency toward action? So let me define another term as we get into these questions. And let me define situational awareness. This is the perception of environmental elements and events with respect to time or space, the comprehension of their meaning, and the projection of their future status. It is, in essence, a tool for us to use as we move toward action to ask and answer those critical questions that might inform the approach we take. Now, you'll see three emboldened terms within that definition. One is perception. How can we identify key data and contextual elements? Comprehension. How can we employ analytics to consider their meaning and significance? And third, projection. How can we think ahead, forecasting what might be coming in ways that can drive us toward action? But of course, a starting point is returning to those critical questions. And that's where I want to go now, starting with this first question of why certain children are more likely to face preventable morbidity and mortality. Why was the child I met in that trauma bay that night there in the first place? Why was she someone who experienced the terrible outcome that she did? Well, we know that there are many factors that influence or determine health outcomes. You heard the term social determinants a moment ago. I'll come back to that in a moment too. But we know from the National Academy of Medicine that medical care is insufficient for ensuring better health outcomes. We know that social conditions, policies, and programs influence health outcomes across the life course. That new payment models are prompting interest in addressing not just medical factors, but socioeconomic factors and environmental factors which influence health outcomes. And that the integration of social and medical care are becoming more common, particularly as we pursue experimentation. This particular figure, which comes from the Robert Wood Johnson Foundation and County Health Rankings, thinks about the relative contributions of these factors. And though I don't think that we can often or only say that these percentages are true across the board, the take home here is that health or medical factors, clinical care in particular, account for a minority of what determines health outcomes. And pertinent to the conversation today, items like air and water quality, housing quality, transit, those types of exposures can be thought to contribute at least 10% of health outcomes. I would suggest that they likely contribute more than that. And so here's that definition of social determinants of health, a term that Mary Jo introduced at the outset. Here, the definition from the World Health Organization is those conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. The figure on the right of this slide comes from Healthy People 2030 and illustrates some of the domains in which we may think of the social determinants of health. And again, pertinent to our conversation today, the neighborhood and built environment provide a sizable chunk of the puzzle. They influence exposures inside and outside that in many respects help to determine health outcomes. And it's through the ways in which these factors determine health outcomes that we may think about health equity, the distribution of those outcomes. Here, a definition from the Robert Wood Johnson Foundation for Health Equity ensures that we understand everyone to have a fair and just opportunity to be as healthy as possible. This requires us to remove those obstacles or barriers which may be rooted in the social determinants of health. Things like poverty, discrimination, powerlessness, access, quality education, and yes, housing and safe environments that influence health and well-being for children and across the life course. It's this pursuit of health equity which pushes us to think about the distribution of health outcomes and that definition of population health. So let's think about housing and safe environments and get to the point where we understand why a child like the one I introduced at the start may not have had the same opportunities for a healthy life as those in other parts of our city. These are all pictures shared with permission, some taken by me, some taken by partners at Legal Aid Society, of the homes of Cincinnati's youth, or many of Cincinnati's youth. You see a picture highlighting black mold, a rodent infestation, a cockroach infestation, water damage that leads to holes in the walls or ceiling, collapsing ceilings, all indicative of indoor environments and in many respects air quality that places children at risk and diminishes their opportunity for a healthy life. This pushes us to think of a few more concepts: social needs, social determinants of health, and those structural determinants of health equity. In this schematic, social risks and social needs are thought to be those specific risks or specific conditions that could be exposed, that individuals could be exposed to. This is a map of Cincinnati from the Eviction Lab, looking at the distribution of evictions across our city, a risk related to housing instability that many may face. Social determinants of health are related to that, to the social, economic, and physical conditions in which someone might live. Black mold and propensity to live in an apartment unit that is characterized by black mold may represent such an environmental exposure or a social determinant of health. These determinants are in fact determined by other factors themselves too. And this is where we get into those structural determinants of health equity. What are the policies that determine the determinants? What are the structural mechanisms that shape social hierarchies? What is the role of structural racism in the perpetuation of health inequities? This is a map that I'll blow up in a few slides so we can take a closer look at it, but this highlights the legacy of redlining and the degree to which that discriminatory practice continues to influence disinvestment in communities even today. Now, in the clinical setting, with this idea of wanting to identify those social risks and needs and those social conditions or determinants that influence health outcomes, there's been a growing push to ask the right question, to screen, to understand the lived experience and lived context of patients and families that come through our door. The National Academy of Medicine now endorses standardized collection of fields like race and ethnicity so as to understand health inequities, as well as items like tobacco exposure, alcohol exposure, and residential address so that we can begin to understand what might be linked to that address. They also suggest that we collect data on items like educational attainment, financial strain, stress, depression, other factors that when integrated with the electronic health record can help provide a fuller picture of the lived experience for patients and families. Similarly, the American Academy of Pediatrics encourages screening to facilitate prevention services and improve the health of all children with this eye toward equity. Again, it's not enough to ask the question, it's that we ask so as we facilitate action and move toward action. I wanted to provide just a couple of examples of what this looks like in practice. This is a screenshot of the social needs questionnaire that we use in our primary care setting in Cincinnati. And I'm not going to go through all of these questions, but you see that we've started to ask questions about threat of eviction or housing problems like roaches, rodents, mold, lead, and more. We ask additional questions about food insecurity and mental health, issues with public benefits, or whether anything scary or harmful has happened to the family since their last clinic visit. Now, there are certainly other examples of social needs screening out there. This is just one additional example called the iHelp questionnaire, where you can see they go through some very similar questions and areas of inquiry. But common to them certainly has been this idea of focusing on housing, housing quality, housing stability. It's also been important for us to think about how to understand the inequitable systems, those structural factors that many of our children and families face. Again, trying to answer the question of why certain children end up in a trauma bay for asthma and others end up in school classrooms without any symptoms. Well, we know that 1 in 6 US children live in poverty. Children are the poorest age group in the United States. The federal poverty level for a family of 4 is now about $27,000 or $28,000, still thought to be just half what is truly needed to meet basic financial security. We also know that a disproportionate percentage of poor children are children of color, highlighting the degree to which economic and racial segregation and discrimination come together. We know that policies like the child tax credit played a substantial, albeit potentially temporary, role in lifting children out of poverty, given that that approach, that expanded approach to the child tax credit wasn't renewed to meet the need that is truly there. And what happens as a result of diminished socioeconomic status, racial segregation, is a truly inequitable result. And so I was just providing some sense of the perception component of situational awareness. Now, here we get into comprehension. This is the first of a couple data slides I'll show on racial inequities and hospitalizations across conditions. Now, the child I introduced at the start identified as Black or African American. We know in Cincinnati, like most of our cities across the United States, that children of color are disproportionately impacted by morbidity and mortality. This is a chart looking at hospitalization rates per year by race, by some of the most common diagnoses we see at Cincinnati Children's Hospital. As an example, if we look here at the diseases of the respiratory system, we see that the admission rate for Black youth is double that of non-Black youth. The ratio listed on the right highlights that this ratio is above 1 for all of the conditions that we assess in this particular chart, no matter whether it be diseases of the respiratory system like asthma or diseases of the digestive system, the nervous system, or mental and behavioral reasons for admission. This next chart is looking at data in a slightly different way, capturing the number of fewer admissions we would experience per year in Greater Cincinnati if Black youth had the exact same admission rate as non-Black youth. That top row is asthma. So if you look in Greater Cincinnati, our metropolitan area, we would need to prevent approximately 300 asthma admissions per year among Black youth if they were to have the exact same admission rate as their non-Black peers. Again, highlighting the degree to which we have very real inequity here in our own backyard. Here's another chart. This is looking specifically at asthma and asthma admissions normalized by population for kids in Southwest Ohio. So the y-axis is that asthma admission rate, the x-axis is time. The individual dots represent monthly data, and then the lines represent 12-month moving averages. The orange line is that for children self-identified or parent-identified as Black or African-American, and the blue line represents all other patients. And the main point here is that there is extensive gap across the board. We saw that gap and the overall admission rates went down in the early phases of the COVID-19 pandemic, but we've seen that those numbers have come right back up in the last several months. And in fact, the admission rate for Black youth is 6 times greater than that for non-Black youth. As we look at this, we can see the direction in which those lines are going, the projection of where we expect to go in the coming months, unless we take action. So let's now move to that next question. Why are certain communities more likely to face preventable morbidity and mortality? And I'd like to start by going back to this picture. This is the redlining map from Greater Cincinnati, or from the city of Cincinnati. This is a 30s era map, and it was pulled off this really wonderful website that I encourage everyone to look at, distributed by the University of Richmond, which looks at historic redlined maps for cities all across the United States. For those not familiar with redlining, it was a 30s era practice which essentially wrote discrimination into lending practices with legislation. And certain neighborhoods or communities were outlined in a different color, red, yellow, blue, or green, based on discriminatory and in many respects racist or anti-immigrant sentiments that made certain communities less lending safe than others. And this led to very low opportunity for home ownership for some in certain communities, and it has influenced the investment in those communities to this day. And so this map, it's hard to see some of the colors that are on this map. For some cities, it is far easier to see when you look at their red line map, but I'll just highlight the ramifications of this 30s era practice today. One of the neighborhoods that was in red on this map was the neighborhood of Avondale. According to most recent data from the Cincinnati Health Department, the life expectancy for individuals from the Avondale neighborhood is about 69 years. If you go just 3 miles to the east in the Hyde Park neighborhood, a neighborhood that was green in that 30s era map, the life expectancy is 84 years. So a difference of 15 years separated by three or so miles, about a 10 or 15 minute drive time. And a very real ramification of processes and discriminatory practices that were put in place nearly 100 years ago. Of course, I should also mention that the child I introduced at the start was a child from that Avondale neighborhood. So let's look at some other data. This is looking at neighborhood all-cause inpatient bed day rates per 1,000 children per year. So in other words, we looked at all reasons for kids to be hospitalized, all days kids spent in the hospital, and counted out those number of days for each of the 80 or 90 neighborhoods that make up our county. And then we divided by the total number of kids within that county. So the y-axis of this chart are the 85 or 90 neighborhoods that make up Hamilton County, Ohio. The x-axis is that inpatient bed day rate. And the thing that I want you to make sure you see here is the sheer variability as you scan from top to bottom. There are some neighborhoods with relatively low admission rates and some with quite high admission rates. The Avondale neighborhood, which I mentioned before, is up here in this the top quartile, or the gray quartile. And when we look at census data that characterize these different quartiles of communities, you see real gradients as we think about the degree to which the population identifies as Black or African American, again, highlighting the degree to which economic and racial segregation go hand in hand in cities like our own. You see other gradients present for things like vehicle accessibility, or children living below the federal poverty level, or households on public assistance, renter rates, vacancy rates, all indicative in many respects of housing quality and stability. This next chart looks at data much the same way, except specific to asthma. So in many respects, asthma is one of those key conditions driving inequities across the board. Here we see an 80-fold difference in asthma hospitalization rates across our neighborhoods, with some of those same neighborhoods lighting up over and over and over again. Some of those same neighborhoods lighting up for outcomes like life expectancy. So how do we get there? How do we find our way to an understanding of certain children, certain populations, certain communities with increased rates of asthma-related morbidity and mortality? There was a really interesting paper from the New York City Department of Health that focused on inequities in COVID-related outcomes that we've kind of adapted for our use in helping to think about asthma. So in that paper, they note that anti-Black structural racism drives health inequities through a cascade of factors and has manifestations warranting dedicated analysis and response. So in other words, here's our inequitable outcomes. We have increased rates of morbidity and mortality among kids and populations as it pertains to asthma. But as you move progressively upstream, there are increased rates of asthma-related ED visits and admissions, increased rates of poorly controlled asthma, and perhaps increased prevalence of asthma, all that occurred in a stepwise way to drive that downstream outcome open still further. So what are some of those common drivers? Why might we see increased rates of morbidity, increased rates of potentially preventable utilization, increased rates of poor control, increased prevalence? Well, these are just some of the possible examples, but common to them relate to items like access to healthy environments, access to clean air to breathe, absence of exposure to harmful environmental triggers, all which begin to lead to that cascade along each steps in the path, and that are influenced and bolstered by structural, environmental, and proximal factors influencing why certain patients, certain populations, certain children, and certain communities disproportionately experience the bad of the social determinants, while others disproportionately experience the good of the social determinants. And so we want to try and get to a point using this frame of situational awareness to think about how we might align a system as a truly cross-sector health promoting system, taking all of the understanding that we might get at a city level to drive down towards change at both a patient and a community level. So this is a map of Cincinnati. The background colors look at rates of poverty. There are neighborhood boundaries on there, and there are a number also of health promoting factors and partners that you see. Hospitals listed, you see schools. You'll hear more about school-based health centers a little bit later in our session. You see other health promoting agencies like food pantries, or potentially health promoting or health harming public housing units, ways in which we might think about what's the system in which children find themselves. We might take a deeper dive into a particular neighborhood. This is the Avondale neighborhood. What does that mix of risk and resource, risk and asset look like as you get finer and finer and finer? And how might we think about it finer still, with children and families at the center of what we're doing, with alignment of those other sectors in service to better, more equitable outcomes? And so with this idea of the social determinants of health being central to what we do, how can we understand the degree to which social risks and needs, such as a family living in poor housing with exposures to lead or mold and an unresponsive landlord, how can we link them to resources like the City Health and Building Department, health law partnerships or medical legal partnerships, all in the name of better, more equitable outcomes, all in the name of ensuring our progressive move toward providing that opportunity to be healthy, that opportunity to thrive. So with this, I want to come to the last question that I posed at the start. How can we use shared situational awareness to move with urgency toward action? One of the ways we've thought about this is really going from organization to improvement, identifying the right stakeholders and partners that need to be around the table, coming up with plans that are co-produced, aligned, and developed in ways that pursue execution on agreed upon performance metrics that allow us to gauge our progress toward improvement and adjust actions based on that which we learn. This, in many respects, is built off the concept of the learning health system. So this figure comes from the Agency for Healthcare Research and Quality, where a learning health system is developed such that practice informs the data that we collect, which helps us to generate evidence, which informs the practice. This systematic cycle where we learn from what we do, adapt what we do, share what we do, and apply the most promising evidence to lead to the best outcomes possible. Our team recently published core practices for the pursuit of equity within a learning health system framework. And here are the 7 core practices we listed. This idea first of establishing principle, positioning equity as an essential focus of everything that we do. Measurement, tracking those data that allow us to understand if we're moving in the right direction. Ensure that there is leadership from lived experience, that those who have that lived experience, those who are on the front lines, are leading and co-producing the work in meaningful ways where we design, create, learn, and act together. Highlighting the importance of redistributing power, understanding where power can be reallocated, and distributed leadership can be the norm. Also practicing a growth mindset, enabling an environment that allows us to understand where and how we can grow, how we can teach, and how we can learn. And ensuring that that engagement, and I certainly say this as a physician and a member of a hospital faculty, that we must engage beyond the healthcare system, that the reality that we've seen that health is influenced by so many factors outside of the system requires us to prepare in ways to meet the need for those additional influences. So one of the things we've been working to do is to build an asthma learning health system where we work to collaboratively define population and set goals, measures, and theory. We facilitate an organization out of the kind of breadth of potential partners, that we bring data and dashboards to build will and ensure shared purpose, and that we integrate in that cyclical or iterative nature research, practice, and improvement. Now, what you see on the right is an initial stab at the system of partners when we have started arranging an asthma learning health system. And a couple of things you'll notice is a lot of disconnected circles. You'll notice families in yellow is at the bottom and kind of out of the way. This is not necessarily a picture of a system that works for patients, families, and communities. We need to rethink how we're organized and how we are aligned and how we center patients and families to truly move in the direction of a better, more equitable learning health system. And this is the picture that we are working toward. And this is draft. We have, in this particular case, neighborhoods and families and patients, communities, populations truly at the center with networked nodes that encircle those patients, whether it be specific to housing, specific to healthcare and research, to neighborhood, all with this idea that we all have something to share, we all have something to teach, we also all have something to learn and contribute. Part of our work in devising this asthma learning health system is to think about situational awareness and network organizing will make it easier to connect and work together, and we'll get the right resources to the right person and populations at the right time, and in turn close equity gaps. And I'll give a couple of examples here by what I mean by that. Part of this is thinking about adding precision to population health. I introduced the term precision, or I introduced the term population health at the start. Here, out of this paper by Kuo and colleagues in 2019, we got to the sense of how might we add precision, how might we pursue precision population health, where we truly do work to get the right resources to the right person or population at the right time. And this involves three parts of a process. One is surveillance and detection, enhancing a measurement infrastructure that allows us to, again, perceive where we are, understand or comprehend what we're up to, and project where we might be going. That would allow us to predict risk more effectively, and then be able to move in the direction of targeting or tailoring interventions that are co-designed to achieve better, more equitable outcomes. So let's think a little bit about what this could look like and bring some data into the mix. And I'll start with perception, comprehension, and projection of potential asthma triggers. If anybody has been out and about lately, you likely know that we are seeing a rise once again in COVID cases. We're seeing a lot of influenza. We're seeing a lot of RSV, all which could trigger asthma exacerbations and be considered part of that indoor air that our children breathe. Well, a few years ago, we did a study looking at lower respiratory tract infection, hot and cold spots across our county. This is the map, which highlights statistical hot spots for where kids were afflicted with bronchiolitis and pneumonia, likely driven by some of those same viruses. More recently, and these data were updated as of yesterday, so hot off the presses, are a look at ICU and hospital admissions for kids related to influenza over time. So the y-axis is that absolute number, and the x-axis is week. And you can see that over the course of the last few weeks, we had that spike in influenza admissions with some stabilization. We're also looking, of course, at the percentage of RSV tests and flu tests that are returning positive for kids within our system. This provides us with a glimpse into what circulating viral loads could look like that could influence asthma outcomes as viral triggers. What about perception, comprehension, and projection as it pertains to outdoor air quality? This is a map developed by a team led by Cole Brokamp, not a map, sorry, a chart that looks at air quality indices measured over time. We're working to figure out how to get this updated on an ongoing basis and to smooth it out so we might be able to understand what this could mean more effectively. But you see this chart with the air quality index on the y-axis, time on the x-axis, and you can see the cyclical nature which we might come to expect. But as we dive deeper into it, if we understand what the air quality is today, how could we more effectively address anticipatory guidance for individual patients as well as populations who may be triggered by adverse air quality. Another example that is allowing us to look at geospatial distribution across a number of exposures. This has also been developed by Colbrokamp and colleagues, where we have an interactive map where you can turn layers on and off to understand potential risks or assets present within that particular community. So this current base map is showing socioeconomic or material deprivation across our city's census tracts. But you can see a list of a number of other variables that you could turn on and off, some relating to socioeconomic status or access, some related to lead paint indicators, concentration of diesel particulate matter, air toxics, ozone, PM 2.5, all indicators that might help us understand what it is we're seeing in a particular community where a child is emergent from. And this is looking at one of those particular census tracts and the actual data for that tract that could be potentially used to, again, comprehend and potentially project what that child's risk might be or what individuals within that particular community might see as their risk. Another example of how this is working out in real time, one of the neat things about Cincinnati these days is a couple years ago, one of our city council members worked with the city manager's office, with city council, and with the mayor to push through legislation that established the City of Cincinnati's Children and Families Cabinet. And you can see on the left the formal ordinance structure for which this occurred. And its primary purpose was to advise the mayor and council about policy initiatives and to measure and monitor data on the improvement of safety, housing, health, et cetera. One of the key areas that the cabinet has opted to focus on has been childhood asthma. And one of the key areas and potential levers that the city could influence is on housing quality in asthma. So we're in the midst of a data exercise, and I'll walk through a few of these maps to show how we're approaching it. I'll start here. This is a map of the city of Cincinnati. The colors here just represent where essentially population density for children, where are the areas where most of our children live. We then, and under the direction of Stuart Taylor and Joe Michael, two of our collaborators, started to think about the city more like a series of blocks, a series of grids. And so one might identify a specific grid. This is a specific area within our city. This is a specific area within the Avondale neighborhood that I mentioned before. This is perhaps even among the areas where the child I introduced at the start may have lived. We can then understand which of these grids or how many hospitalizations and ED visits for children with asthma emerged from these gridded blocks over the course of a multi-year period. We may also think about which of these city blocks had an excess number of housing or building code violations that may indicate adverse indoor air quality. And then we're now thinking about where these overlap, where these align, where these areas might be that illustrate the intersection between asthma and housing, asthma and indoor air. And we're using awareness of these blocks to influence approaches to addressing need at a block by block, building by building, unit by unit level. This is an example of how we use data to drive shared understanding and move toward action. One of the ways we've thought about this is to say, so what are those other variables that might be influential? How might they lead toward action? I mentioned housing code violations here. This might provide us a way of thinking about where do asthma exacerbations and housing code violations overlap. This can move in the direction of interventions like housing inspection and legal advocacy, which we'll certainly talk a little bit more about during the panel. This is a screenshot directly from our electronic health record that now enables us to order, refer, consult, whatever you want to say, a housing specialist in much the way we would a pulmonologist or a cardiologist. And it also helps us make use of what I alluded to a moment ago on child health law partnerships. These are links to address social and legal needs, often housing, that help help ensure that children, families, and populations have what they have legal right to. And we've shown that legal aid for families is associated with lower hospitalization rates, better health outcomes. And this is just a schematic illustrating that point, that when we evaluated the kids who had received a legal aid intervention, we found that the hospitalization rate in the year after referral was 38% lower than if they had not been referred. So here's the difference here. The orange bar represents those who received the intervention. The turquoise represent a matched control set of those who did not. So very real ramifications of addressing these types of needs. So as I close, I want to really push on this thought of systems thinking, a reorientation toward the system of care and connections between stakeholders that help us to move in the direction of equity, common measures, common objectives, co-produced interventions, repeated evaluation and learning, and a virtuous cycle of enhanced capability and capacity. Really what we're trying to do here as we think about our push towards population health equity is make a discernible choice. This idea that a normal distribution has certain individuals who may do poorly and others who may do well. Our goal is to try and narrow that or eliminate that gap while shifting the entirety of the curve to the right. In the words of Don Berwick, former CMS director and founding member of the Institute for Healthcare Improvement, to do this really requires solidarity, the systems view, where individuals in the US legitimately and properly can depend upon each other for helping to secure the basic circumstances for healthy lives. Now, to close, I'd like to just return very briefly to that child I met during my training. So her outcome was something that sits with me and with so many of us probably each and every day. And I would submit that merely preventing her death would not and should not be enough. We should truly be thinking about how a child like this could thrive and have every opportunity to meet her true potential. This requires us to think about prevention, about how to optimize the environments in which children are born, grow, live, age, in ways to move toward better, more equitable outcomes. And so a few conclusions on this front, some takeaways. First, I would suggest that if neighborhoods, like the one I introduced at the start, can cause or at least influence children to die, so too can those neighborhoods help to influence children to thrive and truly meet their true potential. Second, I would suggest that the pursuit of health equity requires us to identify, confront, and abolish the generational and systemic effects of racism, which truly cannot be separated from concepts like the social determinants of health, lived experience, and the air that each one of us have the opportunity to breathe. Third, population health situational awareness, this idea of perceiving, comprehending, and then projecting into the future, could help us to move upstream more quickly. I used to live in Pittsburgh. This top picture is the Point State Park in Pittsburgh, soon after a bad storm runoff in the Monongahela River. Now, why do I show this picture? Well, that's the start of the Ohio River. The Ohio River flows right in front of Cincinnati. If we think that the quality of the Ohio River is solely localized to what's directly in front of us, without thought about what is upstream of us, we're missing the boat. And with this in mind, with this idea of moving upstream, I would submit that we should challenge each one of us to think of one more thing we can do to contribute to better, more equitable outcomes for children, and to ensure that children are breathing air that is clean and health promoting, not health detracting. I want to just take a minute to acknowledge so many groups and people. I tried to include some of the names of the leads on much of the work that I presented today, but there are so many who contribute to this work across Cincinnati and across our country, and I greatly acknowledge their contributions. And thank you for joining today, and really look forward to the conversation again with 3 additional panelists who have been such wonderful partners and mentors of mine. So thanks so much.
And thank you, Dr. Beck. That was such a wonderful presentation. I love especially hearing about, the population health situational awareness. This cycle of perception, comprehension, and projection can help pinpoint children with asthma in poor housing, and how collaborations then can link the social risk with the social assets to help these children thrive. It was so wonderful. Thank you again. And I know there's a lot of excitement and questions in our audience. And so now we will transition to our panel. So first I'll introduce our panel. Today we are pleased to be joined by Dr. Lisa K. Crosby, who is an advanced practice provider and the clinical director for primary care, school-based health centers, and outpatient medical and surgical subspecialties at Cincinnati Children's Hospital Medical Center. Dr. Crosby received her BSN and DNP at Wright State University in Dayton, Ohio. She completed her master's degree at the University of Michigan and is a Duke Johnson & Johnson Nurse Leadership Program alumna. She began practicing as a pediatric nurse practitioner in 1990 and has practiced at Cincinnati Children's Hospital Medical Center since 1991. In her role, she is involved in asthma care and school-based health with a focus on serving underserved communities. She's actively involved with the Avondale community promoting child health and wellness. Also joining our panel is Dr. Maurice Amin, who is the Assistant Health Commissioner at the Cincinnati Health Department. Dr. Amin's education includes a BA in Psychology and Neuroscience from Miami University, an MS in Experimental Psychology from the University of Texas at San Antonio, and a PhD in Epidemiology from the University of Cincinnati College of Medicine. Dr. Amin's interests are to identify risk factors associated with poor overall health, to improve vulnerable populations' health outcomes through public health support and advocacy. She's over 19 years of diverse experience in research ranging from basic science to applied epidemiology, developing studies and analyzing results, peer-reviewed public health research. Her previous experience with environmental health exposures focused on the effects of lead exposures in children. She works closely with public health staff to ensure Cincinnati residents receive the best services to improve the health of the community. Finally, to round out our panel is Dr. Pat Ryan, who is a professor in the Departments of Pediatrics and Environmental and Public Health Sciences at Cincinnati Children's Hospital Medical Center and the University of Cincinnati College of Medicine. He is the Associate Director for Research in the Division of Biostatistics and Epidemiology, co-director of the graduate program in clinical and translational research, and director of the Translational Workforce Development Core for the Center for Clinical and Translational Science and Training. Dr. Ryan is an environmental epidemiologist with a research focus on air pollution exposure assessment and the role of indoor and outdoor environmental toxicants on pediatric health, especially respiratory and mental health. In addition, his research includes the use of personal air monitors in health centers and epidemiologic studies and the impact of naturally occurring elongated mineral fibers on pulmonary disease in the Western US. And finally, we're joined by Kate Hastings, IED's program contractor for over 20 years, who will help to facilitate today's conversation. So I'd like everyone, if you could turn on your cameras and we can go into the panel view.
Thank you, Mary Jo. Thank you, Dr. Beck, Dr. Errico, Dr. Ryan, Dr. Crosby, and Dr. Amin. It is a pleasure to have your full team. And as Dr. Beck made a point for all of our audience, this is a fraction of the team behind some of what we heard about today. It really takes an entire community coming together with leadership from many sectors. And so we're very pleased to have this set of leaders join us. And as you come in, let me ask you for a minute from your team's perspective on the work we just heard about. Is there anything you want to highlight or emphasize or just tell us about your part of this great work that we heard a little about? And Dr. Crosby, I'm going to start with you if I can, because I know your role is right there with those kids when they first hit that hospital.
Hello, everyone, and thank you for having me. Yes, I mean, my passion has been children in schools since the early 2000s, which simultaneously was also involved with asthma in that program in school-based health. So I've worked within our schools. Obviously, that means partnering with our community, partnering with the schools. Also with our organization, we've had a very strong emphasis on asthma. Initially focused on evidence-based care, but now, as Dr. Beck said, we really are looking to expand that and how do we still obviously provide the best care, but do that with our lens looking at the environment as well as those social determinants of health, because all of those variables really play into best care. So thank you again, and happy to have more conversation.
Thank you, Dr. Crosby. And Dr. Amin, I'm going to ask you the same question because I know you're in public health, and maybe you can share for us from your perspective anything you want to emphasize or spotlight.
Sure. Good afternoon, and also thanks for having me. I think, my background in epidemiology and looking at the data, but from public health, we look at it, from a public health lens and what can we do to improve the outcomes in the community. And I think, as Dr. Beck had mentioned multiple times, this is really a collaborative effort, and it certainly can't be done alone. And so, having the systems level approach and, just thinking what can be done from a community perspective and what can be done from a provider perspective is really key to, I think, improving the outcome for the kids of our community.
Thank you. And Dr. Ryan, you have such an interesting and broad background, and you have so many hats. Can you answer this question from any one of those hats you'd like to put on as you reflect on today's presentation?
Sure. I think I'd like to highlight just two things. One is, as an environmental epidemiologist, I and in the field, I think often thinks about environmental exposures kind of one at a time. We focus in on something. And we don't take a step back and think about the context in which these occur, both with other environmental exposures, but also in the communities that they occur in the context of the family situations, the housing characteristics that Andy talked about. And so that's what makes this work so exciting for me to be a part of, because it kind of brings, those environmental exposures that we think about as epidemiologists, environmental epidemiologists, but also, in the context, the family and the community in which they occur. And then the other thing I just wanted to sort of emphasize, Andy had the summary at the end about bad neighborhoods and bad outcomes. And I think he also talked about redlining, and what kind of gets me excited about this work is the opportunity, if we think about bad neighborhoods, bad outcomes, maybe good neighborhoods and good outcomes, same with policies. Bad policies like redlining led to bad outcomes. And I think we have an opportunity to change that with good policies leading to good outcomes at individual and local levels as well as national levels. So.
Thank you. I know that you have a bunch of people who really appreciate that comment and agree with you and are working hard to try to create those policies at all levels. Let's get right to some of the questions from the audience. First of all, we had a bunch. Folks can't wait to see your slides again. They loved the presentation. The maps were incredibly exciting. I mean, you all know this about the data as you've built it and revealed these things for yourself. One of the questions that came, and I'll ask each of you to think about this for a minute, this is amazing. How do we get here? And what if we don't have these kinds of resources? So if we can roll it back a little bit and think, how can a community that maybe doesn't have this level of resource start to approach population health situational awareness? Because there's a lot of data, and it doesn't have to be perfect to reveal insights that can make us better. So maybe you could each share with that. And my mother raised me to start with the ladies, so I'm going to start with Dr. Crosby first. Dr. Crosby.
I would say very simply, one child at a time.
Mm-hmm.
Being in the school, it's a very different environment. We were fortunate and very proactive at the time that we started, But sitting within that school, although we are part of Cincinnati Children's, it's a very different entity, a very different feel. And literally, it was our work and our passion with one child at a time. And as you do that and you start, your learnings are amazing. And if you're fortunate enough to have the data connections and resources, because we are connected to Cincinnati's Children's, as well as partnering with the community, with the Cincinnati Health Department, you continue to spread that. But really, I'd say just start simple and do what you can. Focus on that child and improving that child's health in whichever way you can do that first. You don't have to do all those pieces at one time either. But really just start one child at a time.
Thank you. Dr. Amin, you're next.
I would say, as Dr. Beck had highlighted, the lived experiences, really talking to the families, because the data is so valuable and it really gives insight to what's happening, at a granular level and system-wide. But the families really can give a lot of insight that the data may not be able to provide, and may give direction that is unknown previously. And it's, it's an easy resource.
And Dr. Beck, how about you? Can you think about when you were first starting to build some of the data assets to inform improved clinical practice? Where did you start?
Yeah, I totally agree with Doctors Crosby and Amin. And I think I'll provide one example. So that screenshot of that order from our electronic health record is something that we're, continuously working to optimize. The origin story of that, and I think it aligns with the one patient or one child at a time. It also aligns kind of like with the one partner at a time, or start early. One of the origin stories of that was me and one of our research associates going into a patient room now 10 plus years ago, talking about the potential supports that our partners in public health could provide, and then calling the city's environmental complaint line with the family in the room, just walking through the process that way. So it was very much like a lived example of what that is. One other thing I would say that I think also gets at the start before you're ready, or don't let the perfect be the enemy of the good, or any number of these kind of cliches, is that if you think certain data would be really important to understand, but you don't have access to it, start to put together a prototype, and it could be blank or it could be fake data. And even going to that with a placeholder sometimes helps ground a conversation in a really meaningful way.
Dr. Ryan, that was me mouthing. Dr. Ryan.
Yeah, and I guess I would just add that, a lot of what Dr. Beck showed, I mean, the hospitalization data, maybe not, but a lot of the other data is freely available online. It's amazing what data is out there now from a multitude of sources. And I would just maybe point out a couple, since we're here with the EPA, the EJ screen. You can zoom in on your census tract, right? And you can see a whole list of things. So if you wanted to think about your local areas and from the exposure, the risk standpoint of things, or the populations, it's all there in that EJ screen, a fantastic tool. So a lot of that data is out there to get you started.
Thank you for that. And I just want to echo the idea that there is all kinds of data out there that can help us improve our analytics. And what does that mean? It means bringing data to look for patterns in what can the data tell us and what can we do with those pattern recognitions. And that can be, that pattern recognition happens with all kinds of observable data. I want to ask you another question. The questions are blowing up, as you can imagine, and we're going to run out of time, of course. We will do what we can, audience, to get answers where they're possible. We will be posting resources on the Asthma Community Network, and you will hear about that because you're here. We'll email you. An interesting question, and this is a tough, I'm not sure who to put it to, so I'll put it out and whoever wants to can pick it up. There's a question about Medicaid's involvement or any other healthcare payers' involvement. I'm sure you can imagine the many reasons folks are wondering. Maybe Dr. Beck, I can start with you. I know you have a hand in the ACO that might help folks understand.
Yeah, honestly, and I would also look to Lisa because she's been involved over the years too. But as a starting point, so in the intro, one of the things that got mentioned was an entity here in Cincinnati now called HealthFine. HealthFine is our partnership with CareSource, which is the largest of the Medicaid MCOs in our part of the state, to essentially put about 120 or 130,000 children in Southwest Ohio into an ACO-like model, so a value-based model, where we're increasingly thinking about what are innovations or investments that can be made to drive toward better outcomes. It's this merging of, mission, this is the right thing to do, with margin, that it may also be the cost-effective thing to do, which I think is opening up some new opportunities for us to both enhance our analytic capabilities for, projection and use of resources like RN and social work care management, community health workers, and then social or environmental interventions like legal aid, all of a sudden are becoming part of the the value equation that in my mind begins to align the financial with the ethical or moral imperative. So I think there are a lot of opportunities there. I think there are increasingly more and more value-based approaches to medical or healthcare that are going to enable us to think a bit more outside the box about where we direct our resources.
Dr. Crosby, how about you? You want to add anything there?
I mean, obviously, I agree with Dr. Beck. And pre-ACO, we had often reached out to our Medicaid partners to ask them, and it was a two-way conversation at all times, but we created an asthma care coordination program years ago, actually, where we did partner with one of the primary Medicaid organizations here in Cincinnati, and they actually provided funding for us to do some of this work. They had a goal, we had a goal, and we got together and talked about what that would look like and how could we do that. In my experience, there can be some bureaucracy, but again, I think everybody wants the best outcomes. So really just taking that initiative, having those conversations, having patience, but really starting small. Again, what do you want to see happen? And again, we've had thankfully many years of doing this to get where we are. But if you're starting smaller, which we did, honestly, you just have those initial conversations and get that Medicaid buy-in, because it's going to benefit them if their patients are healthier out of the hospital and not having frequent utilizations.
Thank you so much for that. I want to encourage anyone on this call with questions related to this to please go to the Asthma Community Network, look at the micro site on financing, reimbursement for asthma home visits with environmental interventions, tons of webinars. This is a topic on which IED's asthma program is very passionate, has a lot of information. So talk to us outside of this webinar and look at our past webinars. This is something we're very I like what Dr. Crosby just said. Medicaid has goals, you have goals, get together and talk about them, find where they overlap and find ways to work together. And then, yes, be patient. There can be some bureaucracy, that would be true. I have a really hard question, Dr. Ryan, that I've been hesitating to put forward but you are an environmental epidemiologist. So this is a really tough question because I don't think anyone knows how to solve the model to answer it, but it's important. So let me put it out there anyway. Do we have any way to recognize what contributions are from outdoor air pollution versus what contributions are from indoor air pollution and how they are affecting health outcomes? As our environmental epidemiologist, this is an opportunity for a 101 from you, please.
So a couple of thoughts. So I think, traditionally we've looked at outdoor exposures, modeled them, measured them, because, from a regulatory standpoint, that's what, EPA can do something about, right? But I think we all recognize that, what 85% plus of our time is spent indoors, right? So the indoor environment certainly plays a really important role. And I'm really excited. So one of the areas of research that I do is the use of monitoring technology, low cost and some higher cost devices. And especially as we're talking about data, the amount of data and the real-time monitoring that you can do now, especially with low-cost sensors, and actually, measuring things inside of the home has become much, much easier for us to do in our epidemiologic studies. So, for example, we can get now real-time temperature, humidity, and PM 2.5, for example, from a low-cost device, transfer it via cellular networks or Wi-Fi networks, and see it in our computers at our research labs near real time. So opening up the doors of potential almost real-time interventions if we'd like. So I think back to the question of, do we know now? I think we have an idea that the indoor environment obviously plays a really probably outsized role in the exposures that we get, and probably a major component of the health outcomes. But I think we're just starting to scratch the surface about the data that we can collect to really quantify that, and then hopefully intervene on that. And I guess I'll leave it there if others want to add to it.
Anyone else want to add to that? Dr. Errico, of course, you're welcome to if you'd like.
Yeah, I'll just add yes to all of that. In our division, we'll be putting out some guidance on using those kind of indoor sensors soon. So yeah, definitely exciting research going on right now in that field.
Thank you. I always think about it that we're 90% of our time indoors, and whether a pollutant originates outdoors or indoors, it's getting into my lungs and my bloodstream when I'm indoors, and that's where I'm going to do something about it. So I'm more focused on the what can I do about it indoors, because there I can maybe do something. So that's my 20-year 2 cents on that. Other questions we've had, and we'll maybe end with this one, because I think it really illustrates some of what you're doing in practice with this data and how you're using your whole community system. Dr. Amin, I'll start with you and ask others to follow on. There's a question about the legal aid partnership and what are you able to do from a public health standpoint with, for example, when you were to utilize it, legal aid partner. Can you describe a little bit of what might happen in that partnership in your system and how that works?
Sure. So from the public health department standpoint, we have the ability to do inspections on homes related to any poor housing conditions, whether it's owned or tenant occupied, and then we have the ability to do enforcement. And so enforcement will help to remediate that issue, and very often working with legal aid, as they are also helping out from the housing perspective and trying to improve the housing conditions of families that they're working with.
Anyone else on the team want to describe any of this?
Yeah, I'm happy to just dive a little deeper into the medical legal partnership model, because these exist all across the country. I think when I last checked the National Center for Medical Legal Partnerships site a few weeks ago, they listed about 400 of these all across the country. We've had a medical legal partnership, that was the child health law partnership that I mentioned, in our primary care centers now for about 15 years. And it is a link between patients we see in our clinics with legal aid advocates, attorneys, paralegals, who are able to help navigate risks for poor families that in many respects have a legal bent to them. So the two most common reasons for referral to our med legal partnership at any given time are public benefit denials or delays. So someone who has kicked off food stamps and they shouldn't have been, or housing related challenges, either eviction or conditions. The conditions work has in many respects enlarged to be a partnership that is kind of like the city action that was described. So it can include housing attorneys and paralegals. It can include public health personnel, sanitarians, building inspectors, city policymakers, and then some of our community-based organizations who can fill in some of the gaps around enhancing housing conditions. And it's become a really wonderful additive to the work that we can, or the supports that we can provide. People with expertise in an area that, we as clinicians don't always have, and can, consult them much as we would a cardiologist.
I keep muting myself to make sure I don't talk over you and then forgetting to unmute. Thank you very much. We have a question. A lot of people are asking for the list of principles for a learning health system. So that was that topic of what is a learning health system again? Wait, who's doing a learning health system? That really got a lot of attention. Maybe in our last minute, you all can talk about what a learning health system is just a little bit more. There might have been a little misunderstanding that it's a clinical discovery tool. Go ahead, it's enough, I think.
So
Andy?
I'm happy to start, but I was also looking at Lisa because I know she's been part of this for a really long time. In a 10-second version, it is a way in which real-time learning and data influence the questions we then ask for research or iterations on enhancements to the actions that we pursue. And the idea is to expand the lens so that it's not just, a clinician acting in isolation. It's a clinician and importantly, a family who are co-producing health. It also includes researchers and those across a more broadly conceived system of public health professionals and community-based organizations and policymakers. But the kind of central tenet is this iterative cycle of learning, action, learning, action, learning, action.
Dr. Crosby, can I give you the last word on that before I close us out? Anything you'd like to add?
Sure. Just in simple terms, it takes a team, right? It takes a village. So everybody brings their different expertise and their knowledge. And I think historically, health systems or healthcare providers have been seen as that. They have that medical piece, but that medical piece only. Meet the children where they are, and where are they? They're in school, they're in daycare, they're inside. And who are the people helping them be where they are? So it literally takes a village, and that's really what the system is about. You take that one learning, you take that one child, you multiply it. It may or may not be applicable, but again, you're learning as you go. And there is no right or wrong answers. It's what this individual child and family needs to be better, and most importantly, to keep that child healthy.
Thank you, Dr. Crosby. That is a beautiful sentence for us to end on. I went long with the questions because there were so many. So Mary Jo, I know I left you no time to close, but I felt this was such an important conversation. Back to you, my dear friend, Dr. Errico.
Thank you, Kate. And thank you, everyone. That was just a wonderful discussion. Again, a wonderful presentation. Thank you again. So now as we wrap up, I would like to ask our audience to please take a moment to revisit the poll to help us assess if we are meeting our goals to support learning and action on population health situational awareness. As a group, do we feel more ready to use data analytics to inform asthma home visiting programs after listening for how we can adapt and apply Cincinnati's lessons in our communities? I'll give a few more moments for people to answer the poll. I think we can see the results of the poll now. Thank you, Pierce, and that's great. Now many more of you are familiar. That is wonderful. I'm glad you enjoy the presentation. You can go to the next slide. I want to remind everyone that on asthmacommunitynetwork.org, you will find recorded webinars, including this one soon, and others such as our webinar featuring US EPA's 2022 winner of the National Environmental Leadership Award in Asthma Management, which was Utah's Medicaid and Public Health Partnership, as well as the first webinar in our series, which was from California on Medicaid innovations that are financing in-home asthma visits with CHWs and funds for home remediation and modifications. By joining the network, you can also make sure to hear about the next webinar we will host in this series on solutions for the IEDOH when it is announced, as well as a wealth of resources. Next slide. EPA's learning objective for this webinar series is to equip communities and asthma programs with the knowledge, examples, and insights they need to get into action to put comprehensive asthma care systems that can address the IEDOH in place for all children with asthma. This is our objective because we know that when those systems exist, we can deliver on the vision that we know is possible, where all children with asthma who need them have access to environmental asthma home visits to bring their asthma under control and to eliminate pediatric asthma disparities. Though each community and state strategies may look different and different mechanisms for payments, workforce, data, and delivery will emerge, each suited to the state, policy, and asthma burden, we know there are common strategies that work for building, getting results with, and sustaining comprehensive asthma care systems. And we at EPA IED are here to help every community nationwide to take them. So thank you. That's the close of our webinar.